A picture for the gala dinner tonight, and don't forget to complete your exhibition passport and return your entry to the registration desk. Tonight's gala dinner will be taking place in halls F and G in the Adelaide Convention Centre from 6:45 p.m, and please bring your ticket along with you. Please take note of your nearest exit, which we have just one, in case of the emergency, and please follow the instructions of the Convention Centre staff. If at any time you need assistance, please see the conference company team member at the registration desk. And I'll just introduce you to my co-chair.
My name's Anusha. I'm a paediatric intensivist at Starship Children's Hospital, and I'd like to invite our first speaker, Dr. Georgia Brown. She's a paediatric cardiac intensivist at the Royal Children's Hospital in Melbourne, and she's going to be talking to us about the view from the front, future directions in cardiac ICU. Can we give her a warm welcome, please?
Hi. Morning, everyone. Thanks so much for coming along, getting out of bed this morning. I've been tasked by Dr. Miller to talk about future directions in cardiac ICU. I'm the newest member of the gang in the cardiac ICU in Melbourne. So I'm going to talk about future directions, but before I start talking about that, I'm just going to talk about the present day. I was on service in the cardiac ICU last week, and these were patients that I was looking after. I rolled into work and got told by the overnight reg that the switch that we did for a transposition had an unexpected cardiac arrest overnight that required CPR in the chest to be reopened. We had a 5-day-old with pulmonary atresia post-BT shunt who had an open chest and mainly due to post-op hemorrhage. We had a 6-month-old 5-kilo baby on a Berlin heart for dilated cardiomyopathy that had very erratic anticoagulation and now developed a thrombus, needing the device to be switched out. And we also had a 2-week-old arch reconstruction with a smallish LV who was not quite right after the LA line had been removed. So these are pretty standard patients, but I'm just going to go through quite a number of different things. Some of them are actually in the ICU, a lot of them are outside of the ICU, but they're going to influence the way that we manage our patients in the future. And so maybe the course of these patients could be different related to developments that are going to come. So the first thing I'm going to talk about is catheter-based interventions, which is one of these things. It's not actually an ICU intervention, but the more that we use it and utilise it, it's going to change the way that we manage our patients. The particular thing that I want to talk about is duct stenting for patients with duct-dependent pulmonary blood flow. So February 2018, there was a bumper issue of the circulation which had 2 studies related to stenting of ducts in patients with duct-dependent pulmonary blood flow. One was from North America and one was from the UK. This one was published by Andrew Glatz, and it's basically a retrospective review of multiple large centres in North America, including CHOP, Texas and Cincinnati, comparing their experience with either BT shunts or ductal stenting. What they showed is that there was no difference in the primary endpoint, which is the patients were fine, they didn't die more, and they didn't need more interventions prior to their next procedure, which is generally a BCPC. They also showed that the patients that had the ductal stenting stayed shorter times in the ICU, they needed less diuretics, they had lower procedural complications, and they had better pulmonary arteries before their next surgery. The findings of that paper was pretty much mirrored in this paper. This is the UK study, which is a retrospective of a national database. Some of their biggest cath centres are in Leeds and in Gosh. And they showed actually that there was the people that had the babies that had ductal stenting were better, did better than the other patients. They had an early survival benefit and they required less ECLS support after their procedures. Some of them failed though, a small proportion of them failed, or 1 to 2 in 10 needed to get off the table in the cath lab and go to theatre and have a BT shunt afterwards, and their group found that maybe those babies needed a few more interventions in the intervening time, so they needed fairly close follow-up. Obviously these 2 studies are both retrospective, and there's a plan to do a prospective study comparing the BT shunts with ductal stenting, kind of similar to the Norwood-Sarno kind of studies that have been done. But the translation into real life for this with me, looking after these babies, is that the post-procedural stay is very uncomplicated and brief, but getting them to the stent is actually very challenging. Usually the good candidates for a stent are the smaller babies or premature babies that you don't want to undergo a surgery and go on to bypass. but often proportionally they have a large duct. So if you stented that duct, they would get torrential pulmonary blood flow. So often those babies were in the ICU for a time on some support, sometimes developing neck with pulmonary overcirculation, and often because they were small, they would need the surgeons to collaborate in order to give vascular access for the catheter doctors to get their stent in place. I think you're going to see as it emerges over time that collaboration between teams is something that plays a huge part in kind of all the things that I'm talking about. Toronto had this fairly novel method, which is not really evidence-based, but they would basically turn their prostate on and off, 12 hours on, 12 hours off, as a way of trying to see whether or not that would shrink the duct. When the first time I heard that, I was horrified. I saw it in 4 patients while I was there. It did make the duct smaller, but not without a lot of stress during those 12 hours while it was off. And there's no evidence for that. So the next thing I'm going to move on to is intraoperative extubation, which is something that I think that we're going to see. I think anybody here that's managed cardiac patients, and there's always this thing of, let's fast track this patient. The ASD comes back, we'll extubate them and they'll be ready for the ward in 4 hours. 6 hours later you come back, they're still intubated. They've still got their outline in, they haven't gone anywhere. So this is a paper that was written by the Paediatric Cardiac Critical Care Consortium, which is a group of lots of large North American hospitals, Boston, CHOP, Toronto, Cincinnati. And Steve Schwartz wrote this paper. There's not very metrics for which we measure the quality of cardiac intensive care programs, and the duration of mechanical ventilation was something that was proposed as something that we could kind of benchmark cardiac programs with. So they came up with this paper where they kind of defined a model of how long you should be ventilated after particular cardiac surgeries, and then they kind of reviewed the different sites. The results of that is not really what I want to talk about, but they basically looked at over 5,000 patients, and in the 5,000 patients, kind of a third of them were extubated intraoperatively, so on the table. So that's like a large number of patients. So this is a practice that's becoming more and more prevalent. This is a study from Japan where they retrospectively reviewed their institutional experience with extubating patients on the table. They excluded neonates and patients with pre-op ventilation, and essentially their practice is at the end of the case they have a look at the baby, they discuss with the surgeon. Based on kind of 6 very reasonable contraindications, they wouldn't extubate the baby. Obviously, you wouldn't want to be extubated with an open chest. Basically what they found with their experience, these are the kind of procedures they were doing it in: VSD closures, ASD closures, some more complicated things, AVSD repairs. And they were able to extubate 83% of their patients in the operating room on the table. They found that you were less likely to be extubated the higher the RAC score was, and they found that a small proportion of their patients needed to be reintubated, and they would do that in the operating room. And the most significant association was the longer your operation was. So not groundbreaking, but like pretty impressive that they are, for 83% of their patients, they're extubating them and then transferring them to the ICU. They excluded neonates though, so this is a paper looking at preoperative and intraoperative predictive factors to allow you to extubate people, neonates, immediately in cardiac surgery, and it was a single centre, again, retrospective over 3 years. And they included 148 patients that underwent surgery, and they roughly found they could extubate about 30% of them on the table. Single ventricle physiology was less, they were 20%, but they still were, still 2 in 10 babies with single ventricle physiology they were extubating on the table, which is pretty impressive. The most important things I think about this though was the predictive factors where if you were ventilated before, you were unlikely to get extubated. The older you were and the shorter the operation is, you were likely to get extubated. It did have an effect on ICU length of stay, and there was lower costs associated. But the things I've highlighted there are the things that I think is actually what matters in real life. The anaesthesiologist or anaesthetist had a huge impact on whether or not babies were extubated, and also it took longer in theatre. And this is just a small study of 4 patients from Mount Sinai that were extubated on the table after having a heart transplant, none of whom required reintubation, and they all had no significant complications related to it. But the things that I highlighted is the anaesthetist and the longer operating time are extremely important. For things like this to be effective, it requires buy-in from every single member of the team. The decision that you want to extubate this person on the table kind of starts way before they even go into the surgery. It requires a lot of support for the nursing staff in particular. I think all of us know a long-term night shift nurse who said, like, the patient that you're expecting to be intubated, ventilated overnight with support is going to be extubated now and you're going to look after them. Without additional support and education, and it requires a lot of change in the way that the anaesthetists manage their patients. Short-acting opiates, local anaesthetic and wound kind of infiltration catheters become much more important. The next thing I'm going to talk about just very, very briefly is mechanical support. I'm not going to spend a long time on it. It's just going to be something that we're doing more and more and more of. This is a model from a Swiss lab that's been 3D printed in soft silicon. It's a biventricular heart that's powered by a pneumatic pump. This has been used in animals. It hasn't been used in people yet. Sorry, this video always flips every time I present it, but this is what we're using at the Children's Hospital at the moment, which is our Berlin heart, which is essentially an extracorporeal pulsatile VAD device. It's essentially a bike pump for a VAD. And the Royal Children's Hospital has a fairly progressive and fairly open-minded approach to mechanical support, and I think over time what we're going to evolve into is, instead of why should we put somebody on a VAD, why shouldn't we? And the indications are going to become broader and broader. The children are going to become smaller. The physiologies that we support, in particular diastolic and restrictive physiologies, and this is a prototype from the Berlin Heart Institute. It hasn't been used in humans yet, but that's essentially a prototype for a Fontan conduit that could be hooked up to a VAD for someone who's a failing Fontan. Anticoagulation, though, in our mechanical devices is a really big problem. So this is basically the device that was switched out of the 6-month-old baby that I was talking about that had erratic anticoagulation, who ended up with a thrombus inside the device. Bivalirudin is something that many larger centres that do a lot of mechanical support are beginning to embrace, but without a lot of evidence base. So bivalirudin is a direct thrombin inhibitor. It doesn't require antithrombin to work. And it seems to have no significant increase in bleeding or clotting complications, and more reliable in terms of monitoring, in terms of PTT and ACT. However, the drawbacks of it is that it's expensive, we can't reverse it, and probably the biggest drawback is that we don't really have any evidence that it's better or worse. This is probably the kind of largest kind of publication about bivalirudin in mechanical support in paediatric populations. There's a study that's a case series basically of 12 kids on ECLS, and this is for VAD, and it's 6 patients. They basically switched from heparin to bivalirudin for a number of different indications. They didn't have any significant bleeding. They had one patient that had a thromboembolic complication. This publication is from Edmonton, and I think Edmonton now is using bivalirudin as a first-line agent for pretty much all of their VADs. But because I'm here to talk about the future, this is potentially somewhere that we could go. Devising a way to prevent blood clotting without the use of anticoagulants is one of the holy grails of medicine, and that's by Don Ingber, who's from the Harvard's Weiss Institute. The picture on the left, which is horrifying, is a carnivorous pitcher plant, which on the rim and on the inside has this non-stick coating. And the team at this lab have developed this system called SLIPS, which is slippery liquid infused porous surfaces. And they developed them originally for kind of commercial purposes. Pretty much everything that we do is developed originally for the army or commercial purposes. And these guys developed this for oil rigs to stop oil from sticking in their pumps. They've then basically teamed up with this medical institute at Harvard, and they've started coating things that we use already. So ECMO cannula and tubing and things like that, and mechanical valves, and they've applied it to it, and it's just shown that the blood won't clot or stick to it. It's also got an application of that biofilms can't form on it, and so it may have a kind of a improvement in rates of things like CLABSI and things like that. They're really, really, really into this in Toronto. They also have a lab there, and I've been to a number of talks about this, and every time they include a video of a gecko slipping down a tube, and so I thought I would as well. It seems to, for some reason, highlight it better than showing the blood one. Yeah. So moving on now, and the utilisation of technology more and more in the ICU. So probably most of you are aware, for the ICU college now, there's now a minimum requirement for focused cardiac echo for all of our trainees. This little device here is called a Butterfly IQ. So an echo machine, a full echo machine, costs about upwards of $100,000. There has been kind of handheld echo devices that you can plug into an iPhone for some time, but they're pretty expensive, around about $10,000. And then this little device now is being sold in the US for $2,000. It's not available anywhere else yet, but it's FDA approved for cardiac echo and vascular access. And this is something that potentially all doctors will carry on them, much like we have a stethoscope or thermometer, or even with the bedside nurses. This article was in the Washington Post last week, and I read it sheepishly because it's basically by a professor of epidemiology telling us how crap we are at interpreting tests. And it's a really nicely written article. It basically makes you feel guilty because of all the stuff that we do wrong. But the most interesting thing about it was this comment by this guy Rafters, who sounds delightful. So, I'd wager a different headline: doctors are surprisingly bad, period. I long for the day the entire medical profession is replaced by advanced robotics, machine that can fully diagnose and treat conditions without having to endure pointless drivel, bad attitude or constant misdiagnoses. That kind of brings us on to the kind of incorporation of technology, data analytics and artificial intelligence. Open disclosure, this is not my area of expertise, but I think if we talk about the future of cardiac ICU, you have to mention it. There's two main bodies that are really working on ICU-related healthcare and adoption of artificial intelligence: Ediometry from Boston and BCare in Barcelona. And basically what they're trying to work on is descriptive analytics, like what is going on. Does your patient have AF or do they have SVT? Predictive analytics, what is going to happen, and prescriptive analytics of what you shall do. There has been kind of I think a mistake by technology companies to imply that possibly that they're going to replace doctors, that we will all be able to just sit at home and wait to be told what we need to do. And doctors have always been conservative about adopting new technologies. And the talks that I've been in about this usually digresses into a fiery argument about people worrying about, being replaced. But I think the more we adopt these technologies, we'll have more time to communicate with families, to educate and research. This is something that I've used myself in Toronto. This is, lots of you will be familiar with the T3 platform, which is basically the real-time kind of use of all of the data which gets kept, and they've developed this new thing called inadequate oxygen delivery, or IDO2 index, which is an algorithm which combines 10 to 12 different markers of inadequate oxygen delivery and then kind of highlights them as a colour. You can see from this example that this was a chest closure. And often prior to any individual values have begun to deteriorate, it highlights you to the fact that this patient is at risk of inadequate oxygen delivery. They're using it all the time in Toronto. It hasn't been validated to actually change outcome, but occasionally it was useful. So in the not-so-distant future, possibly the course of the patients that I described at the beginning would be different. Instead of having a BT shunt, a bleeding complications and an open chest, the 5-day-old with pulmonary atresia would have a stent, be awake and extubated, off all support and ready to go to the ward the following day. The 6-month-old with a clot in their Berlin heart could have that taken out and replaced with one with a TLP coating and therefore wouldn't need anticoagulation at all. The 2-week-old didn't arrest overnight because you got a text message on your phone telling you that they were about to arrest and maybe you should do something about it. And the 2-week-old arch reconstruction with a smallish LV post-LA removal had their pericardial effusion diagnosed by the nurse practitioner that's recently been employed in the cardiac ICU, who's able to use her echo probe. And we also have a female Indigenous Prime Minister. So that's all I've got to say. Thanks so much for letting me speak. And if you have any questions.
I think that's working.
I can talk loud. Georgia, PDA stenting sounds really, really exciting. How are you going to convince our surgeons to perhaps go down that track?
Good question. Look, I think that I think the more evidence we have that it is a really reasonable alternative, so when they complete this prospective study, which again demonstrate that it's a safe option, these are centres that have 5 days a week, full-time cath labs where they do multiple procedures a day. In Australia at the moment, we don't have that level of support, and so it is definitely going to be a steep learning curve. But I think all of these things is that cardiac ICU is evolving in that it's not the surgeons or the interventional cardiologists or the cardiologists or the intensive care team. It's going to be a continuum of care. We all work together and we work for the best interest of the patient. So the more that we collaborate and understand each other, these things will start to improve. But, yeah, give me time. Great. Thanks so much, guys.